Okay, welcome back. It is now time for our second session of the Population Health virtual program. And this is going to be a look into NYC Health and Hospitals SDOH strategies. I would love to once again welcome on Mark Hagland, our Editor-in-Chief here at Healthcare Innovation, who will be moderating this session. Mark?
Thanks so much, Matt, and thanks to you and our audience for returning. It's my privilege and pleasure to welcome Samantha Kumar from New York City Health and Hospitals. Why don't we begin before we plunge into our topic? Samantha, if you could just go ahead and introduce yourself to the audience, your title, role, and just a few basic facts about New York City Health and Hospitals for those who aren't familiar. Welcome.
Thank you, Mark, and thank you for everyone for having me today. So my name is Samantha Kumar. I work on our Social Determinants team at New York City Health and Hospitals. My work focuses on a few areas, including an implementation of our social service referral platform, our data and analytics portfolio, as well as improving access to income support for our patients. In terms of New York City Health and Hospitals, we are the nation's largest safety net healthcare system. We have 11 hospitals and over 70 health centers across New York City. We operate the city's correctional health services, as well as our New York City Test and Trace Corps, which is our city's response to the COVID pandemic. Just some numbers to get a sense of the patients we serve. We serve about 1 million New Yorkers annually. That includes 175,000 admissions and 1 million ED visits and about 3.5 million clinic visits. To tell you more about our adult patient population, about 30% are uninsured, 30% speak a language other than English, and we estimate that about 5% are unhoused. And I think we'll talk more about that patient population in particular later.
Absolutely, thank you. That really, first of all, wow, very large, very big scope. And so a lot that you and your team are doing. Tell us a little bit about the Social Determinants team, the context of your creation, and very broadly what you're working on, and then we'll plunge in a little further.
Sure, I'm just going to start with the definition of the social determinants of health in case that's helpful. So they are the conditions in which we are born, live, learn, work, play, worship, and age that impact our health and well-being. And I also wanted to highlight that when thinking about our work on social determinants that negatively impact health, the role of racism in determining health and health equities is fundamental in our understanding of these conditions that our team works to change. In the context of our team and working in a large healthcare system, we tend to focus on social needs, which are the manifestation of these social determinants of health in an individual's life. It's often difficult to influence some of the upstream conditions within the healthcare delivery system that impact an individual's social needs and the broader social determinants of health. Our team's goal is to affect systems change, to elevate the social needs of patients we serve to the same level as their physical health and behavioral health needs. So I just want to clarify that distinction between social determinants of health versus an individual's social needs. And in particular, because sometimes when we focus on individual needs as a healthcare system, it may lead us towards an analysis that centers on individual choice rather than the systems that are generating the conditions that result in those needs. So it's just important to think about the language that we're using. Our team is growing both in number and work. We're about 17, soon to be 23. We work within the Office of Ambulatory Care and Population Health, so focus on the ambulatory care setting, primary care in particular, but also do work with colleagues in the emergency department and inpatient settings. In terms of our population health approach to thinking about social needs, the key question that often comes up for us is which patient populations have particular needs or social risks, and what are the best interventions to address those needs or mitigate those risks.
Wonderful. I know, Samantha, you had told me that you are live now in terms of social needs screening. First of all, did I Did I state that correctly?
Yes, yeah,
Okay, great.
perfect.
So tell me a little bit about that. Tell us a little bit about that.
Yeah, so one of the ways that our team thinks about our work is how do we support the clinical care teams in identifying and addressing social needs? And there are two kind of interventions that fall into that area of work. One is around social needs screening, where we have a 9-question screening tool available in primary care visits and specialty care visits, where we're screening for particular social needs like food insecurity, legal needs. And the goal is to routinely ask these screening questions as we engage with our patients. Operationally, it's a challenge to implement a screening workflow. It's also a challenge to figure out the right referral workflows to integrate once you identify social needs. But we have started that work as a health system with the focus in ambulatory care. Another way I just want to flag that we think about identifying and addressing social needs is through a community health worker program that we've been growing and thinking about the workforce that can help better assess social needs among our patients and have more of a long-term relationship with patients as they work through their social needs and their own personal priorities around their health.
Wonderful, wonderful. Now, our audience will be very, very interested in the data analytics aspects of this, which I'm sure are super complex. Let's start at 40,000 feet and drill down from there, if we could. Samantha, first of all, just give us a brief description of what you're doing with how you're leveraging data analytics in the broadest sense, and then I'll probably follow up a couple of follow-up questions on the specifics.
Sure. I think of our data work as 3 kind of strategies. One is how do we understand the social needs of our patient population that we're serving? The screening tool is a great way to get at some of that data, but there are other ways, and we can talk about that as well. And then how are we as a system working to connect patients to the services they need to address those social needs? We have a medical legal partnership where we offer free legal services to about 3,500 patients a year. Which patients are being served through that partnership? What are their demographics? What are the types of legal matters that are being addressed? To really understand, like, what are the services that are being accessed and delivered in the context of social needs? And then the third area is to really understand the impact and evaluate, is there an impact on health outcomes? Can we make that linkage to ED utilization or inpatient utilization? What's the ROI of our health system investing in some of these social service delivery mechanisms and interventions? Can we make that connection from the business case perspective? So that's how we sort of think about our data and analytics portfolio as a team.
So I'm going to drill down about 20,000 feet from there. Have you developed codes for tagging the various situations that you mentioned? Or is it a lot of this still in free text inside the EHR? Where do the data and information reside, and how are you able to manipulate them?
That's a great question. I think I'm going to use an example to kind of parse that out and how we approach it. So we've worked closely with our data core team, in particular, a brilliant analyst, Laura Jacobson, to better understand our patients who may be homeless or experiencing homelessness. And she looked at a variety of data sources to make kind of a hybrid definition of this patient population that might be experiencing homelessness. So things she looked at were the patient's address. Do they match to some of the known shelters in New York City? Sometimes when a patient may not have a stable housing situation, the registration staff will put in the hospital's address. So is the hospital's address listed for that patient? Are there words, even like keywords like shelter, put in the address?
Right.
We also looked at, does the patient have 10 or more zip code changes in 1 year to get a sense of like potential housing instability for that individual? And then there are other structured fields that might be used, like the screening tool that we talked about. There are also some billing codes that might be used by providers. They're called Z codes, and they're specific to social needs. So there are a few around homelessness that we can search for and see if any of those billing codes have been used. So she did that work to develop this hybrid definition, identified around 20,000 patients in our patient population that met that criteria. And then
did she use, sorry to interrupt, did she use NLP? Was that one of the ways, strategies or techniques that she used to be able to gather all that?
Not quite yet. I think it was more of like searching for, particular keywords, but there's definitely potential, there's a lot of rich information in the social work notes, the primary care provider notes, but we haven't quite gotten to that level of sophistication yet, but we
I'm sure you will
could,
soon.
hopefully.
I'm sure
I was just talking about it yesterday with a colleague.
Okay, great. What are the biggest challenges in organizing this data? And then the second part of the question is, once you've organized this data, executing on it, right? Like you find out that Mrs. Smith has experienced homelessness. What happens then, and how is whatever intervention might occur, if one might, how is that triggered? Like, are there alerts that go to the caseworkers as an inpatient is discharged, or after an ED visit or something? Like, how is the information then acted upon? So how do you organize the data, and how is information acted upon if it is?
That's a good question. So one challenge is, the data sources I just walked through are internal data sources, and often our patients are interacting with a lot of external agencies and partners around social service delivery. So another thing that Laura did in this work was she incorporated a data match with the New York City Department of Homeless Services, using their records of individuals with a shelter stay or who may have engaged with the street outreach team. And that made our hybrid definition even more robust and identified even more patients that may be experiencing homelessness. In terms of like converting that data to action, I think the primary use case for us right now has been more around program planning. So we were able to understand healthcare utilization patterns for the population that meets this definition, patterns with race and ethnicity and other demographics, their behavioral health and physical health diagnoses. So it's helped inform planning for programs like a safety net clinic, which focuses on patients that might be experiencing homelessness. So it really helped us. Like, we didn't know before all of this data work, like what percentage of our patient population may be experiencing homelessness. And now we have a better sense that it's closer to 5%. In terms of like action for the frontline staff, the care team member, the challenge is that people's situations change frequently. So sometimes data, from that data match 6 months ago, that may not reflect where that individual's circumstances are right now, or when they're showing up for a primary care visit or at the emergency department. So we really leverage principles around screening, assessment, to really think about where the patient is in that moment that they're engaging with the care team member, and to talk through what they need in order to address their social needs then. So it's a combination of like programmatic level insights, but also incorporating the work around social needs identification into the day-to-day workflows to address individual needs.
Okay, that really makes sense. In terms of your connections with the social service agencies, as you're doing this data work, is it helping to better facilitate smoother connections so that it's not so hard to connect the dots?
Yeah, I think it's giving us a lot of shared understanding of the patients or clients that we all interact with, but with a specific lens. We also, as a health system, we've been using a social service referral platform called NowPow. I think I mentioned that in the beginning, to help us make electronic referrals for social services, either by using their resource directory to find services and share that information with patients, but also it has the functionality to make direct closed loop referrals. I didn't realize the chat was on. This is great.
It's on, yeah.
I hope more people. I hope more people chime in the chat. I'm just going to finish this thought before
Yes,
I
please.
read that. So that's one way we've been thinking about health IT and sort of facilitating connections to social services is how can we leverage some of these new vendors in the social service referral vendor space to facilitate electronic referrals, generate data on how many referrals are being made, what the outcome of those referrals might be, and then as well as our internal data work to see where there are opportunities to explore.
Understood. I do want to get to the comments in the chat, but let me just ask you, what have been the biggest challenges overall in this work so far of any kind?
We do a lot of work and there are a lot of challenges. I think data sharing in general can be really daunting. And people are, starting to talk about interoperability. How do our EHRs are they interoperable with these new social service referral vendors? Do the vendors, are they interoperable amongst each other? And the problem can feel very looming and complicated as we're like trying to build an intersection between healthcare delivery and social service delivery. And both of those are already complicated on their own. So my advice would be just to start small, think about particular use cases or goals that you have in mind and sort of chip away at the problem. And some of those daunting data sharing questions, they're not insurmountable. It just takes some persistence and maybe peeling away certain use cases that you want to start exploring.
Thank you. I was going to ask you for advice and you already gave it. So that's great. Let's look at the comments here. We have a comment from Alicia saying the commonwealthfund.org is an amazing ROI SDOH calculator using AHRQ data utilization data MEPS. Oh, there's a lot of acronyms in one sentence. This is based on the work UCLA's MBA Economics School, Dr. Victor Tabush developed for the SCAN Foundation. The tool is highly sophisticated and uses many evidence-based case studies, literature reviews to verify the usefulness and potential impacts to building the business case for SDOH. The tool can project out costs to implement PHM programs addressing SDOH, both fixed costs, shared savings, etc., all based on data inputs like meals, transportation, etc., and the impact is delivered PMPM or in other ways as your needs. I have worked with a tool to present that within my organization and is widely well received. IMO, it is a hidden gem for any organization to utilize. Okay, I got you. Do you want to just comment on such types of methodologies that might be helpful to others?
Yeah, I think the idea of ROI and this work around social needs interventions or social determinants of health interventions is something common across health systems. And, the way our team has approached it is one, we drive our work based on what we're hearing from staff and what they're hearing from patients. It's not always about the ROI, although the ROI is important. So I feel like we're often building the plane as we fly it. We're trying to demonstrate the ROI for some of our work, but not letting it hold us back into actually implementing the work. So it's like often happening in parallel. And
there's another, oh my gosh. Anyway, I appreciate that people have shared these links. So anyone who is in this session could just share or save the link for themselves. Anyway, you were going to finish your thought though, Samantha.
Yeah, so I think, ROI, it's definitely an important goal to have in mind in this work around social needs interventions, but it's not the only goal. So we try not to have it necessarily drive our priorities, but help actually support our work to make it more sustainable in the long run.
Absolutely, absolutely. So what have been the biggest lessons learned so far by your team in this work?
Similar to that ROI thought the evidence base for a lot of the interventions in social needs and social determinants of health is still being, fleshed out. There's still a lot to learn. And I think it's helpful to have an iterative process when implementing programs or approaching data questions. And there's a lot that can be learned by piloting. I know it's hard to constantly be in a testing phase when you want to also establish long-term sustainable programs. But I think that flexibility is really important as we, as a health system, but also as an industry, learn about what it means to work to address patients' unmet social needs.
I think that's very important. And how do you see the next couple of years going forward? What will this landscape look like for your organization, say 3 years down the road, if you have the mental energy to think that far along?
Sometimes I do. So I think what's been really great to observe in this work is the culture change that we see at our health system, and in service of our team's goal of elevating social needs to the same level of physical health and behavioral health needs. The culture change is so apparent when we talk to frontline clinicians, doctors, social workers, care coordinators, nurses, where they really understand the connection of social needs to health. And I think that culture change, we've gotten it into the IT space with some of our work with this social service referral vendor and our data work. But it should permeate the health system. It should impact how we think about staffing models, how we think about allocation of space and resources. I think there's a lot more opportunity in the health IT space. We integrated the social service referral platform into our EHR. And I think that signals that this is a permanent part of our work, of our documentation.
Oh, that's great. That's great.
And I think things like that, really contribute. They're both a reflection of the culture change, but also they can drive that change as well.
Well, I really appreciate it. I think that your organization, as well as other public hospital and health system organizations in the largest cities, are inevitably going to be compelled to be pioneers in this area, right? I know you already gave a little bit of advice, but do you have any other advice that you'd like to share for our audience as they begin going down this path?
Yeah, I think my biggest advice is to learn from others and to connect with colleagues in this space. Our challenges are shared, our goals are shared. In my work with the social service referral vendor, we routinely connect with their other clients of other vendors to understand, how have you solved this problem? How have you integrated this kind of platform into your EHR? And there's a lot of also great work and convening happening around, standard definitions. There's a group called the Gravity Project where they're working on standard definitions of some of the terms and data elements that are collected, as well as thinking about interoperability of social service information and data. So I think, definitely talk to your stakeholders within your health system to get a sense of what their priorities are, but also learn from external partners and colleagues and peers, because so much of the work is shared.
Absolutely. Thank you. Anything else you'd like to add, Samantha, on any subject? Well, related to this.
Just looking at the chat, it looks like folks are having some.
Yeah, and I'm going to say something about that in just a second.
Okay.
Do you have anything substantive you'd like to also share?
Not right now. I think I would love to hear from the audience, or if there are any questions.
Yeah, if there are any other questions, we just have a minute. What was shared here so far was the Commonwealth Fund, the general link, and you can go to commonwealthfund.org. And then there's also a link for their ROI calculator, commonwealthfund.org/ROI-calculator. But if you can't there's also, someone also shared commonwealthfund.org/ROI-calculator-app. Okay, that covers all the links that have been shared so far. So anyone who is interested should write that down. Casey will send the links out via email to those who have asked. So thank you very much, Casey. Okay, I guess there aren't other questions. So I just wanted to share, Samantha, first of all, I think what you and your colleagues are doing is absolutely wonderful. I want to wish you absolutely all the best in it. And I also think that this is where healthcare is going in this country. And organizations are learning. We're very early on in this kind of work. I often tell audiences I'm kind of fascinated by the early history of telephones and automobiles. If you read about it, it's really interesting because people couldn't quite figure out how to set up a phone system. They couldn't quite figure out how to standardize car manufacturer. That's why Henry Ford came along and we had the assembly line. At the beginning of car manufacture, it was actually custom made. And people were putting the brake in one place on one car and in another place on the other. And so some cars had the brake where the gas pedal was on others. You can imagine how that went. And the early phone systems, there was a fascinating documentary about the earliest phone system which was actually in Kansas City of all places. But you could only, it was subscription based, and there were 4 systems, and you could only talk to people who had your subscription. So if your sister-in-law had a different one, you couldn't talk to her. So eventually they figured it all out. That led to the creation of the Bell system. And per this topic, the analogy is, I think what's happening now with social determinants of health, data analytics, and incorporation into broader operations is people are like your organization are starting to figure things out really well, and then others will learn from the templates that are created.
I hope so. Yes, and I hope to learn from others who have figured things out that we have not figured out, because that is
you're
a
about on the
long
leading edge,
list
so they're
as
going to
well.
rely on you. So thank you so much, Samantha. We appreciate it tremendously. I know I've learned a lot, and I want to wish you and your colleagues all the very best as you move forward.
Thank you.
Thank you so much. Matt Rayner is here to conclude the session.
Yes, thank you, Mark, and I'll echo that. Thank you, Samantha. A great conversation and a look into NYC Health and Hospitals SDOH strategies. We now have one final break before our final session, which will be at 2 o'clock Eastern time, and that will be a panel discussion on delivering behavioral healthcare in a virtual environment. So we will see you all back here in about 30 minutes at 2 o'clock Eastern time. Thank you so much.